And for Dr. Randy Resnik, this is actually, Randy, your 18th appearance on this webinar
Wow.
series. I think we're going to have to
Amazing.
retire the trophy. We just always get great feedback, so we're just delighted to bring you back again. He is the director of the Resnik Implant Institute, which is the premier implant training program in the country. He's the author of 2 recent textbooks, Mish's Contemporary Implant Dentistry and Avoiding Complications in Implant Dentistry. He's a frequent contributor to Chairside Magazine, and his topic today is one that generates lots of questions. It's really important to Gary Pritchard, so I think it's such an important topic for us to cover. So to present part 2 of his series on occlusion for implant restorations, here's Dr. Randolph Resnik. It's all yours, Randy.
Okay, thank you, Neil. It's great to be back again. This is going to be part 2 of our occlusion series. So we actually have 5 lectures that we'll be going over in the next probably 6 months. So if we talk about occlusion, you have to understand the fundamentals and the principles behind it. So I'm going to do a quick recap of what we talked about at the last course. First of all, occlusion studies. If we look at the literature is basically very difficult to understand and to get a conclusion on. There's no generalized consensus. If we look at anything in medicine, when we decide on a particular say medication or procedure, we look at what the studies show. The problem with occlusion studies are they are basically all over the place. As I went over last session, most of the literature are case studies or expert opinion. There's very few really good cohort studies, and with occlusion, you can't really, it's hard to evaluate, say, hyperocclusion on patients. That would be unethical to do that, and to do a controlled cohort study, randomized study, it's very, very difficult. But there is some good literature, which I'm going to talk about today, a lot of meta-analysis, systemic reviews on some of these case studies and expert opinions, and that will kind of give us a basis for making conclusions on these topics we're talking about. Secondly, we talked about teeth and implants. There's definitely a difference in that. When you look at a tooth versus an implant, there is a difference in force distribution, the perception, occlusal awareness, and the way patients perceive the mastication, whether it's the efficiency or how they adapt. So there are significant changes or differences with that. If we look at the bottom line, what we concluded at the last seminar is that teeth and implants are different. What we have to do is control or decrease our occlusal load on implants, because teeth can take a lot more force than implants. And we know that when we put too much force on an implant, that results in bone loss. So with that being said, we talked about all these principles that are called implant-protected occlusion, which was devised and partially by Carl Misch in the early 90s. Some of these topics apply directly to our today's topic, which is single and multiple implants. So with that being said, part 2, the first part we're going to talk about is the principles that apply to restoring a single implant or multiple implants together. The second part is going to be controversial topics that are associated with single or multiple implants, such as, should we split implants? Should we attach a tooth and an implant together? Why is the maxillary cuspid implant the most difficult implant to restore from a occlusion standpoint? And what happens if you have proximal contact loss, probably the most significant or the most common post-op prosthetic complication now in implant dentistry? So we're going to cover all that today, and then I'll do a recap at the very end. So if we look at principle 1, our occlusal forces ideally should be directed along the long axis of the actual implant. We know if we have an angled force or a non-axial force, that develops a shear force. We know that bone is weakest in shear. We know that bone, the crestal bone around the implant, takes most of those forces. And because bone is stronger in compression than shear, when we do have an off-axial or a non-ideal force like that, we become susceptible to getting bone loss around our implant. So how do we prevent that from happening? First is the implant positioning. When we have non-ideal implant position, yes, the labs can give us all these great looking crowns and perfect for maybe aesthetics and function. However, to load them on the long axis of the implant can be very difficult, if not impossible. Secondly, an often not looked at procedure that patients need to be explained at the beginning is occlusal contacts on the opposing dentition. Usually when you lose a tooth, especially if it's for a long period of time, you'll get super eruption of the opposing occlusal contacts. So ideally, look at that before you start the treatment. Tell the patient, Mrs. Smith, when I put your final crown in, I'm going to have to adjust your upper teeth. It might need a root canal. It might need a new crown. But this way, the patient doesn't feel that you adjusted their perfectly good tooth to make your ill-fitting crown feel better for them. So if you look at this second image that I have, this x-ray, this one actually has a shelf on it. So the prosthesis should have never been made like that. Adjust the opposing, make it an ideal plane of occlusion, then it's better for force distribution and preventing that occlusal overload. If you look at this third image, here is a molar that has bone loss. You don't see bone loss on the bicuspid, you see it on the molar. Why? Because there's a huge plunging cusp, most likely the lingual cusp, the maxillary first molar plunging right into that. That is a shear force. Again, the weakest bone is around the crestal area, and you end up with bone loss, which ends up into peri-implant disease. So if we look at principle 2, we want to minimize our cantilevers. Now, everyone thinks about cantilevers as adding another tooth to the prosthesis. That's not actually all there is. You can have a cantilever mesial distally, buccal lingually. So it all depends on the design of the prosthesis. So we want to minimize our cantilevers. So if we first look at the mesial distal cantilevers, so I have them here highlighted in yellow with the arrows. These are the more difficult ones to adjust because usually this is within the confines of the prosthesis. However, we want to minimize them as much as possible. How do we do that? Again, we go back to implant positioning. We don't want to have an implant that's not an ideal position. Then we have to add a cantilever tooth. Or if you look at the second image, it looks like a ski boot. This gives us shear forces, which leads to bone loss. Again, not being able to direct the occlusal loads on the axial of the implant. So if we look at controlling contacts, here's a x-ray of a molar with a huge mesial cantilever. So what we want to do is direct our forces right over that implant body. But if you can see the occlusal morphology here, there are definitely cusps from the maxilla hitting into that mesial area, again causing shear forces. So you want to avoid these marginal ridge and these shear forces from these extensions. We know one thing, that when we place an implant, let's give an example of a molar. The lower molar, mesial distal diameter is approximately 10.5 millimeters. What size implant do we usually put in a molar? Say 5 millimeters. That means right off the bat, we have over a 5 millimeter cantilever on the mesial and distal. If it's placed equidistant, now we have 2.5 on each side. So you want to prevent those marginal ridges, because if you have a patient that puts a lot of parafunction or high occlusal force, that's going to put damaging forces on to the bone level. Secondly, buccolingually, we want to narrow the occlusal table. As I said, our implants are a lot smaller diameter, 5 millimeters. They're not large. They're not a 10 millimeter natural tooth. So what we want to do is bring in those occlusal tables to direct those loads more on the long axis and prevent any eccentric contacts. So if you look at this clinical image on the right, these are two molars. They're not in a aesthetic area, so it's not a big deal to narrow the occlusal table, and it makes it a lot easier and better biomechanically. So buccolingually, we know that these forces are multidirectional, and we have to be very careful. So especially on this case here with the two molars, you can see this whole buccal area is going to be a cantilever, and that also gives us a ridge lap, which causes more peri-implant disease. So right from the design, and here is the design of a natural tooth, 3 and 5 are implants. So when you design these or instruct the lab not to do these full contour crowns, so you can bring back the occlusal table, you can minimize the cusp height, and it will achieve the same goal, the function, the efficiency, because you're going to be contacting in the central fossa anyway. So you can see that decreases the stress. It allows that stress to be distributed over the strongest area of that implant and or the bone area. Number 3, reduce the cusp height, which I basically just talked about, and the angulation. Why is that? Because studies show when you have a larger cusp inclination on implants, you have greater force. So by decreasing the cusp inclination by 10 degrees in this study, showed a 30% decrease in the load force to that prosthesis. That is rather significant. So we don't need these 30, 40, 50 degree cusps, because all that does is that gives us shear forces. So back, if we look in the design phase of this, the upper image here is the full contour. Here is how we modify it to minimize those cusps. And when you minimize the height of the cusp, it also minimizes any possible eccentric contacts, such as here, where when the patient goes into lateral excursions, they're not going to hit one of these cusps, which would basically put more force on the area. So principle 4, ideal occlusal timing, and this is probably one of the most important with a single or multiple implant crowns. As we know, a tooth has proprioception. It has a negative feedback loop to the brain that basically will allow that brain to know that you're putting too much force on, or it starts to hurt because there's a nerve in it. With an implant, there is no mechanical reception there, so there is no perception that's going to alert the patient. A lot of times the patient will be in hyperocclusion, not even know it. There's no nerve to get hyperemic to give us a toothache, so the patient can even tell us. So that's why it's so important. We know that when we put a force on a tooth, that tooth is going to move, and that tooth is going to move in two different, a primary and a secondary movement. Basically, the primary movement is the movement of the periodontal ligament. The tooth is going to compress into the actual periodontal ligament. Then the second movement is only going to occur if that force exceeds the physiologic limits of the bone. So it's going to have to be that hard to move it. So most of the time, we're not even seeing a secondary movement. So in contrast, if we look at a tooth or an implant does not have the periodontal ligament, so there's only a primary movement, and that primary movement is analogous to the secondary movement of the tooth. So only if it exceeds the physiologic limits of the bone will that even move, which is very unlikely. Therefore, all that force is going to be concentrated and cause a issue as putting more force onto the crestal area of that bone. So how do we do this timed occlusion? It's very easy. What we do is basically we're going to make an implant crown that is in slight infraocclusion to our natural teeth. So how we got to check it? Step one is we have the patient lightly bite together. Okay, so they're going to bite lightly in centric occlusion. We're going to use thick articulating paper. Okay, and what we want to do is with thick articulating paper, we're going to pull through and we're going to make sure there's no resistance. Why? Because we want that opening or that separation between the implant and the opposing occlusion approximately at least 40 microns. Now, you might say, well, what is thick articulating paper? When you purchase your articulating paper, most people are used to buying the regular, which is between 12 and 40 microns. The shim stock, the very thin, which we will use also, is between 8 and 12. But the thick is greater than 40. So that gives us right off the bat that we know that implant crown is in infraocclusion. So the second part of this is then we have our patient heavily clench. We have them clench as hard as they can. Why? Because we want to compress that periodontal ligament. By compressing that periodontal ligament, now we're going to take thin articulating paper, the shim stock, and we're going to be able to pull it through with minimal resistance. So we'll be able to pull it through, but we'll know that that space now goes down to probably less than 12 microns, and that is timed occlusion. So let's look at what happens if we don't have timed occlusion. And let's say that in light contact, the patient bites down and we can't pull that paper through. What is actually happening is that implant now is actually going to occlude first. So the teeth will not be able to, their periodontal ligament will not be able to be compressed. So what will happen? The implant will be in hyperocclusion. And because we don't have a nerve to it, there's no nerve to the crestal bone area, the patient never knows until it's too late, until we start losing bone loss. So that's timed occlusion. Light contact, 40 microns, should be able to be pulled through. With heavy contact, compression of the periodontal ligament, then we have resistance of shim stock or very thin articulating paper. So if we look at number 5, we want to make ideal occlusal contacts. Now, everyone remembers from dental school where you look at the cusp-fossa relationship and you're trying to get as many contacts as possible and this and that. If we look at natural teeth, if you look at studies, and this is a systemic review that looked at patients, actually how many of the natural teeth, how many contacts there are. And with over 50 studies, they've evaluated this question. The average is between 11 and 64. So it's basically a range. So there's so many factors that come along with it. But what is significant about teeth? They adapt. They can move. There's a periodontal ligament. Teeth will move if they're in traumatic occlusion, they will adapt. However, with implants, they don't. So of course, there's no in vivo studies on this. There are a lot of in vitro studies, and this is one of the better ones that looked at the number of occlusal contacts. And basically what they looked at as, is it better to have a single area such as that red circle in the center of the tooth, or is it better to have also green, which is on the inclined planes, or blue, which is even higher up on the cusp tips? And what they found out was the lowest amount of stress to the area. And these are finite stress analysis, so they can tell where the stress is going. The least amount of stress was when you had a broad contact in the central fossa and no inclined plane contacts. So the bottom line is that is the ideal occlusal contact in the center, more of a broad where on natural teeth, we have multiple contacts per teeth. So in summary, when we have a natural tooth here on the left, when the patient bites down, it distributes the force over a larger surface area. However, with an implant, what we need to do is go over that long axis of the implant. But what we don't want is this. Here is two teeth, number 3 and 5, and the same occlusal contacts or the same size of contacts as the implant, which is number 4. That shouldn't be the same. So again, the implant is going to be a lot smaller. So any of these contacts outside of the diameter of the implant are going to be shear forces, which again, the implant cannot adapt to. How do they adapt? They lose bone. Or you have a mechanical complication such as a fractured prosthesis, screw loosening, anything like that. If we look at other in vitro studies, this is really a good one that takes two situations in the concern, and they evaluate the contact area and also the occlusal table, whether it's narrow or wide. So if we look at if the patient in this example, if the occlusal contact is in the central fossa, whether it's a wide or it's a narrow occlusal table, guess what? There's no detrimental forces because that is giving us a compressive force. If anything, that is going to be beneficial because bone is strongest and reacts the best to compressive forces. However, if we take either the wide or the narrow and move that contact outside of the central fossa, put it on the cusp tip, now what happens? You can see the detrimental forces and the impact. All those forces are on the top part of the implant. Usually the first 3 to 5 millimeters is going to take all of that force. That's why we get crestal bone loss. So the bottom line on this study, whether it's wide or it's narrow, the more important factor is the central fossa loading. So we don't want those cusp tip loading because that's going to lead to shear forces. So the bottom line, concentrate the forces in the actual central fossa. So what is our final design? Let's have a summary on this. Ideally, if you look at the schematic on the left, we want to concentrate, we want our contacts to be in the central fossa where I have is green. We want to minimize to not have any at all on marginal ridges or what we call mesial distal cantilevers. And then to get rid of the buccolingual cantilevers, we want a low cusp inclination and a narrow occlusal table. When you do all that, that concentrates the forces more on the long axis of the implant and allows that implant to distribute the forces better and to prevent occlusal overloading. Now, what specific clinical situation do you have to be concerned about? And I've seen multiple cases of this where anterior implants. So in this example that I have, number 10 is an implant. All the other teeth are natural teeth. So why is the anterior implant with natural teeth a very difficult situation? Why do we have a greater risk of premature contacts than, say, on the posterior single tooth? Well, basically, it's horizontal movement of the teeth. You can look at this diagram on the left. We have a lingual force, so the patient is incising or masticating. And what happens? That tooth is compressed facially. So when you have a tooth, the tooth will move. Why does it move? Because it's made to move. If we look at horizontal movements of all the teeth, this is of the maxillary teeth, you can see that the anterior move a lot more than the posterior. And that is part of mutually protected occlusion. We want the posterior to protect the anterior so this doesn't happen. However, we make it happen when we have, in this situation, a lateral implant. So if you look at the contact on that lateral implant, you have to be very, very careful that you don't overload this. So when you have that patient clench, you really have them clench as hard as they can. You also check the anterior guidance. So you make sure that when they come in to protrusive, that they don't have a long contact on that implant crown. Because if you're only checking the occlusion in with light contact, then that implant can be in hyperocclusion, mainly because of the movement of the other anterior teeth. A great way to evaluate that is with the T-scan. And this is a great little instrument in our prosthetic course. We have everyone do this on everyone. And it's amazing when you go back to the number of contacts. It's amazing how, we're always taught that every tooth has multiple contacts, but when you start evaluating patients on a computer like the T-scan, you'll see that that is not true. So it's rather alarming when you do see that. Okay, let's finish this up on principle 6, maintain mutually protected occlusion. Again, mutually protected occlusion definition is the anterior teeth protect the posterior teeth. How do they do that? The canine discludes, separates the posterior teeth, the incisors and the canine, they take care of our anterior guidance, which again discludes the posterior teeth. So this cuspid is very, very important for this disclusion. When we look at the posterior teeth, when the patient bites together, the posterior teeth are, the reason their surface area is so great is they're going to take the majority of the force. Because they take the majority of the force, they're going to take the pressure and the stress off of the anterior teeth. So the bottom line is we want to maintain mutually protected occlusion in these situations. So that concludes the single and the multiple implants. Now, the second part of today's webinar, I'm going to talk about controversial occlusal topics such as splinting, implant to teeth connection, the maxillary cuspid, and proximal contact loss. So first, can we splint or should we not splint? Should we leave them independent? If we look at the literature, this is even more wild, and there is definitely no general consensus on it because it is very difficult to measure and to research. So the studies are rather limited on this. If we look at just the advantages, why do people like to take multiple implants and not split them together? Well, seating's easier. That's what people say. I don't know about that because now you have all these contact areas, but that's what the textbooks tell us. Patients can floss. Patients have a more natural feeling. These are the advantages of keeping the implants independent. Now, what are the disadvantages? Well, we know from biomechanics that right off the bat, when we splint, it's a lot better. So if we have two independent crowns, biomechanically, it's not going to be as good. Insertion time, I believe it does increase insertion time because we do have contact points that we have to adjust in a lot of situations. So let's look at splinting. There's a whole slew of advantages of splinting. And let's go through some of the more common ones. First of all, engineering-wise, biomechanically, in vitro studies have shown that implants, when they're splinted together, are exponentially stronger than independent implants. So let me put that in English. If you have two implants and if the patient bites down with, say, 50 newtons of force, that prosthesis, those two implants, if they're not splinted, can withstand 2 times 50 newtons, which is 100. If you do splint the two implants, now that whole prosthesis is 50 squared. So biomechanically, it's a lot stronger. And that is why, if you look at biomechanics, that's why we have a high success rate with all-on-4 and doing 4-arch immediate load prostheses because we're splinting them. If we didn't splint them, we certainly wouldn't have the high success rate that we do. It gives us a greater AP spread. So we know that when you connect two implants together, you have a greater anterior to posterior spread. What does that do? That allows the force to be distributed over a greater area. We know from studies that there is a less fracture rate. We see more fractures on single implants than we do with splinted implants. We know that studies show that implants that are connected have a lower chance of screw loosening than if you have one single implant by itself. And we know that in cases where our prosthesis space, the amount of space that we have from the tissue to the opposing dentition or occluding surfaces, if that is compromised, sometimes we have retention problems. If we splint them, now that increases our retention, and it's a lot easier to keep the prosthesis from becoming uncemented. What are the disadvantages? The big one is hygiene. So everyone says, well, you can't clean if they're connected. People talk about the impression technique. If the implants are placed in the ideal position, that shouldn't be a problem. But if they're not ideal, it can be a problem. And seating of the prosthesis. Sometimes it can be more difficult to seat if they are splinted. So let's look at some systemic reviews and meta-analysis on it. And there's not many. So I'm going to give you two, the ones that are more recent and that are clinically relevant. If you look at regular size implants, greater than 10 millimeters, and if you look at peri-implant disease and implant survival, splinting versus no splinting, there's no difference. And no study has shown if you splint two implants, you have a higher incidence of getting peri-implant disease. That has not been shown. This study or this meta-analysis also establishes that. This study is a good study from the J. Perio Journal, a meta-analysis systemic review that looked at shorter implants, compromised in surface area, basically implants, and situations with increased restorative area. And they looked at implant survival. What they found is splinting in these situations does prevent implant failure. So in this situation, it is better to splint than no splint. So with that all being said, let me give you a recommendation because it is so conflicting and controversial. This is what we recommend that you look at. First of all, this is not a cookie cutter way of protocol. You have to look at each case individually. You have to look at each clinical situation. Look at the force factors, which is the most important. Look at the implant factors, the size, the diameter of the implant. Look at maxillomandibular relations. Say, do we have an excessive restorative space? And look at, see the patient's past history. Do they have, if they had a history of proximal contact loss? These are all things that need to be taken into consideration. So let me give you two clinical examples here. This case in the upper left, if you look at, this is a compromised restorative space. Crown implant ratio is definitely compromised. The implants, there's two implants that were not tied together. And what do you have? You have a crestal area force that most likely caused an implant neck fracture. So most likely if these were connected, that most likely wouldn't have happened. The one on the right, now we have a very uncomfortable restorative space, really bad crown implant ratio, and we have very short implants. To help with this, because now that becomes a vertical cantilever, we're going to want to splint. So in summary, compromised restorative space, non-ideal implant size or dimensions, patient has parafunction, or if we have poor bone density, such as we have here in the posterior maxilla, where you don't have that cortical bone to really withstand the stresses of those occlusal forces. So, second controversial subject, can we connect an implant to a tooth? Does it make sense? In my career over 35 years, this has gone back and forth at least 5 times. Yes, you can. No, you can't. If we look at history, the top image is a blade implant. Bottom image is a unilateral sub. We used to teach weekend courses on just blade and subperiosteal. They had high success rates, worked very, very well. But what was interesting about both of those treatments, we always connected a blade to a tooth, and we always connected a unilateral sub to a tooth. And they work very well together. However, with implants, there is a lot of literature out there that says you should never do it because of the biomechanical mismatch. Then is some literature that says you can do it. Then there is some literature that says you can, but you have to take certain precautions. And again, it's a case-by-case basis. So let's look at the history. A lot of the early pioneers in implantology will know about this. The IMZ implant was a German implant that actually had what was called an intramobile element. And we used to put these implants in, place this intramobile element, which was supposed to simulate the movement of a tooth. And what would happen is it did work. It was a good idea, but what wasn't taken into consideration is the forces on implants are multi-directional. If this was a axial loaded force, that would work. So these intramobile elements were very fast. They were difficult to change, and that implant kind of came and went. If we look at tooth implant versus just an implant fixed partial denture, there are some systemic review and meta-analysis. This is one that shows no difference between tooth implant and implant, just implant supported, with implant failure, prosthesis failure, and survival rate. However, this meta-analysis did find that when you do connect an implant to a tooth, that does have greater marginal bone loss than an implant-independent prosthesis. The second is looked at tooth and implant failure, no difference. Prosthesis complications, no difference. Prosthesis failure, no difference. And biologic complications. Biologic being defined as basically peri-implant disease. So that really didn't show any difference in that. So what's the bottom line? Can we do it? Yes. There is supportive literature that says that this is a procedure that is definitely not below the standard of care. However, ideally, implants should be separate from teeth. So let's look at it. If you have to connect them, how do we do it? Well, there's a lot of people talk about using rigid connectors or what is called a stress breaker. So should we do it rigidly where we just connect the implant and tooth together, or should we put a stress breaker in between to kind of counteract those differences in force distribution? So what is the issue with the non-rigid connector? Well, if you can see this x-ray on the right, I have an arrow of that tooth. What ends up happening is the tooth is stressed more than the implant because the implant doesn't move, the tooth does. And what ends up happening is tooth intrusion. So what exactly is tooth intrusion? Well, basically, that's what happens. The tooth intrudes into the alveolus, and then you're in infraocclusion, such as that upper right area. So you can see where the tooth, the female part of that attachment has gone apically. Why does it happen? No one really knows. Two theories: periodontal ligament compression, the constant back and forth compression, non-compression. And what that ends up doing is you lose the seal on the prosthesis and then it intrudes. Another possibility is the periodontal ligament, because it's not being stressed ideally, goes through disuse atrophy, and then the tooth intrudes into that space. No one really knows. We only have in vitro studies on this. Here's a in vitro study that looked at non-rigid connectors, increased stress on the prosthesis, and definitely increased stress on that crestal bone area. We do have a lot of case studies, expert opinions with non-rigid connectors and tooth intrusion. With rigid connectors, though, we have the same case studies and expert opinions with almost no tooth intrusion. There is only one meta-analysis that has looked at this in systemic review, and this is one from Clinical Oral Implants Research, and where it showed 0% on rigid connectors tooth intrusion, about 8% with non-rigid connectors. So the bottom line is if you are going to connect, you don't want to use a non-rigid connector. So if we look at what's the recommendation here? Give me a textbook way of doing this. Here's what my recommendation is. If the risks out far or greater than the benefit of doing a particular treatment, then go ahead and add it to an implant. I have two situations here. Patient has maxillary rhinosinusitis that can't be treated. Therefore, the only way, since you can't do a sinus lift, you're going to have to attach an implant to a tooth. That would be one. Second, let's say that you have a type 1 nerve, high mental foramen, you don't have enough bone. Vertically, you don't have enough space to grow bone. Therefore, you have to attach it to the implant. What you don't want to do is use this. The patient doesn't want a bone graft, or the doctor says, I don't do bone grafts, so I'm just going to do it. I would try to stay away from that because you will be Monday morning quarterbacked on that. So the recommendation, very quickly, simple tooth to implant connection. You want just one implant, one tooth, one ponic, no stress breakers, no telescopic copings, just a rigid connector. When you evaluate the abutment teeth, you want to avoid endodontically treated teeth, avoid parafunctional cases, no cantilevers. So again, just one implant, one tooth, one pontic in between. Okay, we have two subjects left and we're kind of running out of time here. So the single maxillary implant, why am I even talking about that? What am I even talking about? Well, let's say that you're missing a cuspid, so you're going to have an implant on one side and natural cuspid on the other side. What is the problem? The problem is canine guidance. So what we have to do now is, with timed occlusion, we have to time our guidance on a tooth that moves, we know horizontally, with an implant that doesn't. So it's very important that we have canine disclusion, but the difference between an implant discluding and a natural teeth is a lot different. If we look at the canine, the natural tooth canine, it's the longest root in the mouth. Why is it? Because it's probably the most important for occlusion. That's what we disclude off of. That is why it's the longest root in the mouth. Well, with the implant, that doesn't change. So what we want to do is we want to minimize our disclusion. So you can see here in the lower part of this image, the blue is where the ideal contact would be. Ideal, that's where it is designed, but more ideally would be more further anterior or buccally, so that we separate the posterior teeth with a very short disclusion. We don't want a long disclusion because that increases shear forces. So what do I mean by that? That here you can see where you have this long disclusion, and that is all dictated by the design of the prosthesis. So you can see as this diagram shows, when you disclude, you have a very long disclusion. So that's going to be a lot of shear forces. But what we don't want to do is have a short disclusion where we get interferences, because now we go into a group function. So you want to make sure that your cuspid discludes the posterior without making interferences. And then you want to make sure that you don't make the cuspid so short that now you go right in the group function and you have no contact on the cuspid. So ideally, what you want is a very short disclusion where it ramps off of that cuspid, very short period of time, and is able to disclude those posterior teeth. So in summary, a long disclusion results in more force being placed on the implant in the bone, whereas a short does not. Why do we want to try to avoid group function? What's the literature say? First of all, you have to understand the definition group function. That's where you have working side contacts, no non-working side contacts. So here's a study that looked at group function versus canine guidance, greater muscle activity with group function. Here's an EMG study that showed when you don't have posterior contact, so it would be canine guidance, 2/3 of the temporalis masseter muscles don't contract. So with group function, you are going to have those muscle fibers contracting. Here's a in vivo study that looked at fixed prosthesis porcelain fracture, mutually protected 16% fracture, group function over 50%. So a good JPD study. showing that. So the bottom line is this canine is an important site. You want to make sure that you're in good thick bone because it's going to take a lot of force. It should be in an ideal position for the intended prosthesis. And you have to have the correct ideal morphology or contour of the lingual so that you have a short disclusion. Now, there are some situations when you have to have a group function, such as, let's say that cuspid is compromised, it's poor bone, it's been grafted, then you can pick up very small contacts on the bicuspid, which is probably the better, and maybe a little bit on the lateral to help out that cuspid. But to have long, greater group function, the research certainly shows that to be bad. Our last topic is proximal contact loss. What is that? Basically, you put an implant crown in, you lose contact after the prosthesis is inserted. Here's a meta-analysis systemic review that shows from 1 year ago, average is about 41% of implant contacts open up. The range is about 30 to 53%. Mandible is greater than the maxilla. If we look at it, it's usually the mesial. Mesial is a lot greater than the distal. So basically, and it happens in these studies, the average timing was about 3 months from insertion. So this is very embarrassing because what happens, you put an implant crown in, your patient comes back, it's collecting food, they're upset, now you have to redo the prosthesis. Why does it happen? There's 3 possible reasons. The first reason is mesial migration of teeth. As people age, their dental arch decreases in length. Because of that, you have more crowding of the teeth. And because of that, the implant doesn't move, the teeth do. The anterior component of occlusal force is always greater than the posterior component of occlusal force. Therefore, the anterior wins, goes more anterior, opens up the implant. Secondly, poor proximal contact. When you put the prosthesis in, you might have a long very minimal contact, or you have a very shortened contact and not a broad contact. And then thirdly, where the occlusal vectors, the mesial and the distal, don't equal each other, and one or the opposite is greater, and say if the distal is greater than the mesial, then it's going to push it farther to the mesial. So with that being said, how do we prevent this? Well, number one, retrievability. Ideally, screw retained. That's the best way. Then you can just remove it, put a new contact in. Secondly, you can use liners, occlusal guards. The patient has to be compliant to that. This is, I've never seen a study on this. This is how I treat it. And since I've done this, I haven't had it happen where you modify the adjacent teeth, the contact areas. Why you want to do that is, number one, it will allow one path of insertion for our prosthesis. Secondly, it gives us a broad contact like this on the right versus a small little contact, which is on the left. It's less apt to open up with a broad contact like that. So with that being said, what is our take-home message? Our take-home message is there are implant-protected occlusion principles that you can apply to single and multiple teeth. Hopefully you understood those and you can convey those to your lab and implement those in your private practice. There are significant controversial subjects. Hopefully you have a take-home message that they're splinting versus independent prosthesis. There's indications for both. You have to understand when to do that. Tooth implant, you can do it. However, it should be in compromised situations, not on a routine basis. Maxillary cuspid implant, you want a short disclusion and proximal contact loss. It does happen. It's probably the most common prosthetic complication now in the literature. So thank you very much. Sorry, I went a couple minutes over. That was a lot of material. Part 3, we'll be going over full arch fixed prosthetic prosthesis occlusion. So what this will do is we'll go over the all on X type of full arch prosthesis. Thank you very much.
Well, thank you, Randy. What an incredible lecture. So what Nicole has decided to do is she's going to give everybody 1.5 continuing education hours, and we're going to continue. When we have an expert like Dr. Resnik here, we don't want to let him go without getting him to answer some questions. And there's a lot of really, really good questions. But I also must say that some of these questions are, they would require hours to give a good answer. So as always, Dr. Resnik will do his best, but he gives a 3-day program, which is like a prosthetic boot camp. And I would highly recommend people that are asking these questions. These are really good questions, and you should take a look at that course because there's no more comprehensive course in the restoration of implants than that particular course. So take a look at that. That said, are you ready? Let's dive in.
Let's go for it.
So how do you address aesthetics? So in trying to fulfill the principles that you're talking about, sometimes the tooth is going to appear too short or maybe not buckle enough in the individual case. I mean, you can have this same thing happen with natural teeth, but sometimes the tooth isn't going to be exactly where the patient would like to see it because you're following these occlusal principles. Any comments on that?
Yeah, so Neil, if you look back, you've been in implant dentistry as long as I have, and you go back 35 years. What did we do? We put an implant in and then figured out how to put a prosthesis on it, and that was the way it was. The problem that we have in 2024 is that patients want perfection, and aesthetics is definitely part of this. And aesthetics is very subjective. What I think looks great, you might not think looks great, or maybe the patient doesn't think so. So with that being said, to answer that question, if you go back to the prevention of non-axial loading, I had it multiple times, implant positioning. And implant positioning is what it's all about. You can have the best lab, you can have the best restorative dentist, but if that implant's not in the right position, there is no way you're going to make that highly aesthetic. Okay. It's just impossible. It'll be a non-ideal prosthetic design. So my recommendation is that from the beginning, these cases should be prosthetically treatment planned. There should be it's very easy to do on a CBCT now. Basically, you can show the patient what the prosthesis is going to look like before you even put the implant in. Then the implant is put in guided so that it is in that exact position. But if you have a case, say as a restorative dentist, someone sends you a case, the implant may be not in the ideal position, and you have to narrow the occlusal table or minimize the cusp height. You might not be able to do that because of aesthetics and or function. So if I would look at the one violation of implant dentistry on aesthetics and or force distribution, it's implant positioning. And it makes it very, very easy by just developing the prosthesis first. So like we'll talk about this at the next session. What you don't want to do on an all-on-X is to have a representation of a poorly fitted prosthesis or a prosthesis with a closed vertical or the incisal edge is not in the. So bottom line is whether you're placing your implants, whether someone else is placing, the implant position has to be ideal. If it's in the aesthetic zone, it needs to be really pre-planned and you have to see what the patient's lip line is. Are they a lip lifter? Are they going to be not be happy with this if it's a 0.5 millimeter longer than the other teeth? So there's a lot of variables that go into it, but it is a problem, to be honest with you, more a problem when it's non-ideal positioning.
Got it. You mentioned all on X. One of the tenets of all on 4 is angled implants in the posterior. It seems like the idea of an angled implant violates some of your recommendations here. You're certainly not putting the force on the long axis of an angled implant. Are these cases doomed for failure?
Well, yes and no. First of all, if you look at the studies on all-on-X, they're very, very good, but it's extremely difficult to get an accurate assessment of actually how many implants fail. Okay, because a lot of times they're failed and they're replaced. Right? The problem with the all on X, and we'll talk about this at the next course, is if you or all on four, is if you have four and you lose one implant because it's angled and because there's greater force, then you lose the prosthesis. So the restorative dentist is really out. The surgical doctor just puts another implant in. It's not a big deal. But the reason why you can get by with a lot of angled implants is because they're splinted together.
And they're
So the
splinted together from the day of placement.
exactly. So there is no micro movement. We know that if you put an implant in and you put greater than 100 microns of movement on that implant or force that makes it move more than 100 microns, you'll get a fibrous encapsulation instead of bone. So the bottom line is the all on X works because it's splinted and it makes a lot more sense, to do it.
And actually, it's interesting because in Europe, Zest launched the all-on-4 locator overdenture, which was not splinted, and it was never launched in the U.S. because it violated FDA, submissions. But yeah, that was not a good idea. The angled implant for an overdenture doesn't work. Okay. You talked about timing your occlusion. If there's no natural dentition in that part of the arch, how do you time your occlusion?
That is a great question, and that is a problem. Okay. Even more, and I'll give you another scenario that might even be more common than just unilateral implants, is if you have implants that are intermixed between natural teeth on both sides, and the natural teeth are perinaturally involved. That makes it even more difficult. But let me answer your question on one side. You do the best that you can with that. The one, I didn't have time to talk about this, but there is a very good study that looked at, and this is something that can be measured. What happens to a patient's occlusion after they put the prosthesis in? And what happens after is the danger zone is immediately after you place it. Why? The prosthesis, because the bone is not 100% mineralized. The bone is still immature. You're putting a lot of force on right away. You're not adapting or progressively loading it. So what this study showed that over time, like in a year, the patient's occlusion will adapt. So in that situation, what I would do when you have occlusion one side, just implants, natural teeth on the other, you're going to see that patient more often in that first year for timing evaluation. But then it'll get to a point where the patient basically adapts into it. At least that's what the studies are showing.
Okay.
Does that make sense?
Yes. Yeah, it does. And then, you described using the shim stock. When you're timing the occlusion, is the shim stock pulling through with no resistance or just with a very small amount of resistance?
It all depends on what size shim stock. Okay. What I have seen works the best is if you have about a 10 micron. Okay. Then all that we want is there to be slight resistance. So we know that we can get it through. If you can't get it through, then you don't know exactly how much clearance you have with heavy occlusion. Is that okay?
Yeah.
So with heavy occlusion, if we can't pull it through, then our light occlusion might be off, or the teeth might be moving more than what we believe. All these movements that I've been talking about, and what people have to understand are these are studies with perfectly good natural teeth. Patients don't always have perfectly good supporting bone around their teeth. So the teeth may move even more. So say the example I gave with that anterior implant and you splay those anterior teeth out. If the teeth have bone loss or the buccal plate is very thin, you're going to have more movement than what those studies show. So that's why you have to do it by a case-by-case basis.
Okay. I have a bunch of questions here about screw loosening and its relationship to occlusion. In my experience, there's two main reasons why screws loosen. One is that the prosthesis doesn't fit, and the other one is that the occlusion is off. Can you just comment on that? And
Well, I agree with you. You have the two. I think your first one, a lot of people don't believe that, and they'll just keep tightening the screw, and it's actually the passivity of the prosthesis. So if you look at the mechanics of a screw, what happens is when you screw it together, when you torque and put preload in, you're actually stretching the threads of the screw. So if they're not timed right because the prosthesis is not seated right, what you're doing is you're elongating those threads and you'll never get the preload on it. So the passivity of the prosthesis is definitely an issue. And that's why if I know I had to go very fast at the end, if clinicians start to do those guide planes, as I said, do a guide plane on their single implants will drop in seconds. If not, if you have two paths of insertion, it's going to open up and it's going to be more difficult. But let's talk about the second, the occlusion. If you look at why a screw loosens, it can be the repetitive force. Okay. And I believe that is true. There's no real good studies that actually show that, but it makes sense. Okay. Or it could be a combination of what you said, 1 and 2.
okay. Here's a great question. We want to get the occlusal principles that you're teaching. We want to get them on our restoration. Do we have to list all these principles on our laboratory prescription, or does the laboratory understand the basic tenets of implant occlusion?
Well, I go back to stacking porcelain. I know you've done it. It's very easy to stack porcelain if you make a molar with 50-degree cusps. Okay. But try to make it monoplane, it's very difficult. Now, that was back when we had porcelain. However, now with monolithic zirconia, everything is now designed on the computer. So it's a lot easier. And when it's milled, it's a lot easier. So if you take any of our courses, there's one thing I'll say 100 times on every script: narrow occlusal plane, central fossa occlusion, no lateral contacts. Okay. And you put that on. If your lab is not doing that, if they're making the ideal size prosthesis, then have them send you the design before they actually finish the case so that it can be constricted. But to be honest with you, I still put it on everyone, just it's habit, and because I think it's so important.
Yeah, or you could just put you're a Resnik student on your
There you go.
prescription, and at Glidewell they'll know. I just did want to add something to the person that asked a question about screw loosening. This person was saying about a case where the screw was fine for 7 years, and then it got loose, and now he has to tighten it every few months. I would just make sure that you replaced that screw,
Yeah.
because as Dr. Resnik pointed out, they only can handle so many times of freeload.
So can I elaborate on that?
Please.
This is actually interesting because it happened to me. What we found out over the years is the worst torque wrench that you can have is one that breaks. A breaking torque wrench where you torque it and it dislodges. So we thought that was always the most accurate. But what studies have shown is every time it's autoclaved, there's a residue that gets into that mechanism, and your 30 Newton centimeter torque now becomes 31, then 32, 33, up to, they have some 30 Newton centimeter torque wrenches that are over 80 Newton centimeters. So how is that relevant? Because when you put the screw in, if you under tighten it, it'll get loose. Also, if you over tighten it, what will happen is it will get really tight, but the preload over the years does loosen. And what ends up happening is 7, 10 years. I've had some 15 years that just keep getting loose, but you had the right solution. You just have to always change out the screw. So anytime the screw gets loose, there is a reason why it ends. Probably the screw is altered, the morphology of the screw.
Great. Good reminder. Here's a question about when you've got a tooth that has to, or an implant that has to support an RPD. Is it okay to put clasps on an implant crown, or should we do something radical like just go ahead and put a locator and have the partial denture retained by the locator?
So are you saying if you're going to make a partial denture, you have one single implant?
Well, let's say you're replacing one of the abutment teeth for a partial with an implant.
Okay. Okay.
So
So
you're already clasped that tooth, right?
yes. So if you look at what the studies show with RPD and implants, we always thought that, say, if you have for instance, a mandible bilateral distal extension, edentulous, what we always thought is we'd put one implant in the posterior on each side. That would make sense. And that's what we did in select cases. But the studies actually show that's the worst because what happens is then the partial cannot go over the height of contours. So if you have a C class, whatever, it will end up torquing that anterior tooth out. So the studies show if you are going to connect the two, it's better to have the implants as close to the anterior teeth as possible. Leave the distal extension. But to give you a generalization on that question, a locator would be better because a locator will give you the ability of movement in 6 different planes. Whereas if you have a clasp and you clasp a tooth, the reason, if you think a C clasp, when a patient bites down, it goes over the height of contour. Well, you don't want that to happen. It won't happen because it'll bottom out from the implant. And then what you'll end up doing is torquing the tooth laterally.
Great idea. Great idea. So a couple questions about what material is best for implant restorations. We be avoiding zirconia because it doesn't wear as like natural teeth would? Is porcelain better? Is Emax better? What are your thoughts?
Actually, next course, I'm going to go over that because I always run into the question, the antagonistic arch. If you do monolithic zirconia, should you do acrylic hybrid on the other arch? And that's actually the worst. So the studies show that the material should be the same. Ideally, it should be the same. Now, let's talk about specific materials. If you look at wear of teeth, of natural teeth, zirconia will wear natural teeth if it's unpolished. I'm going to show you some studies that with highly polished monolithic zirconia, it actually wears less than regular ceramics. And secondly, in some cases, less than natural teeth on natural teeth. So monolithic zirconia, even though people think it's so hard, if the occlusion's right, if it's highly polished, and I would highly recommend if you adjust the occlusion, you have to get that Glidewell monolithic zirconia polishing kit. I don't know what the name of it is, but there's
Rupture polishing kit.
Okay, thank you. It works perfect because you can put that shine back on and eliminate that from happening.
Yeah, I mean it's almost counterintuitive, but Rella Christensen has done tons of studies for over 14 years, and like you said, she's shown that even though this material is so much stronger, it actually wears the opposing dentition much less than porcelain. The unkindest material is actually porcelain.
And I'm going to show the studies next course. The porcelain is definitely the worst. It is lowest. And there's a question, enamel versus monolithic zirconia, but monolithic zirconia is a wonder material. And when we talk about the complications with hybrid acrylic denture teeth, full arch prosthesis, this has been it's unbelievable how it's changed our profession. So
Great. Great. Another interesting question. How do you adjust these occlusal principles if you're dealing with someone with a class 2 occlusion or a class 3 occlusion, where they really don't have the normal kind of a cuspid disclusion opportunity?
I guess the best way to answer that question is to say that You adjust it as best you can. However, the most damaging type of contacts you can have are excursive, non-ideal, non-axial contacts. So when the patient, if they're class 2 and they do come in the protrusive, you just don't want, you want to try to maintain canine guidance in as well as you can. But class 3 patients and class 2, they're compromised patients. They're difficult. Their occlusion is difficult with natural teeth, let alone with implants.
Very good. Well, I think we knocked out most of these. There's a couple more, but I know you're going to cover them in future lectures. So I'm going to let you go. And thanks to you, Dr. Resnik, for another great lecture. Thanks to our panel, and thanks to all of you for joining us today. And we're going to be off next week for Memorial Day, but we'll be back on the 31st with Dr. Michael Shearer, and he's going to talk about new options for fixed implant restorations. He is the educational director for Zest. So they've got some new options for fixed restorations. So that should be interesting. So thanks everybody for joining us, and we will see you in a couple of weeks. Thank you so much, Dr.
Thank
Resnik.
you.
Take care.
Okay.
Bye-bye.